So I'm actually standing in for Mariana Offner, who is the epidemiologist in charge of the Autism Surveillance Unit at the Public Health Agency of Canada. For various reasons, she couldn't be here today. She'd sent me a relatively small stack of slides to summarize the report, which I could have gone through in about 5 minutes. So I've added a few slides of my own, and I hope Mariana will forgive me for that. She is watching online, so we might get some interesting correspondence from her. So epidemiology, because Mariana is an epidemiology, is the study of disease in populations as opposed to a disease in an individual. And essentially it involves counting. It's really how many people are there affected by a particular condition in a defined population. And we usually have to be very specific about the population that we're interested in. So for ASD in this particular report, the age distribution that was targeted was children and youth aged between 5 and 17 years. We're able to say something about the sex distribution of different diseases. Some diseases, particularly infectious diseases, show striking geographical differences. Over the years, there's been interest as to whether there are various environmental agents that might predispose to ASD, so people have looked at geographical distribution of that condition as well. William was pointing out yesterday that there have been significant changes over time in the prevalence of ASD, and of course that's a challenge to know whether those changes reflect an increase in the true underlying rate of the disorder or whether they reflect better detection. And for a condition like ASD, we're interested particularly in all the things that go along with ASD, particularly mental health issues, the extent to which people are employed in adult life, how well they do in higher education. So epidemiology isn't just about the number of people with the disorder, it's about all the things that go along with it at a population level. And of course, one of the reasons the Public Health Agency likes to provide official figures is that knowing how many people you have with a particular condition in a population is absolutely crucial for service planning and working out how much of taxpayers' money should be allocated to particular conditions and intervening. And for that to be useful information, one also needs to know something about the severity of the disease. So William mentioned yesterday the example of high blood pressure. Blood pressure is sort of continuously distributed phenomena. The costs of elevated blood pressure in the borderline range are trivial, whereas people who have very high blood pressure that doesn't respond to medication can then sustain all sorts of secondary damage to other organ systems and can spend weeks or months in hospital. So knowing something about how severe a disease is very important in terms of figuring out what sort of resources we need to provide. And the full report is available online. Has ACT circulated the link?
We will today.
Okay. So there's a PDF document that you can download. And in the introduction, the team at FAC draw a distinction between two key numbers that epidemiologists like to use, prevalence and incidence. So prevalence is counting how many people in a defined population have a particular condition at some point in time. And the published report focuses on prevalence. Incidence is the number of people born with a condition or developing a condition for later onset conditions in a particular time period. And obviously, for a condition like ASD, where the age of diagnosis is hugely variable from first year or two of life, right, as we've heard today, into adult life, trying to work out incidence figures is extremely difficult. And so most published data tend to focus on prevalence. And sometimes you will hear the term case mentioned, which is a very technical term, especially as it refers to a person. But what it means is someone is a case if they have the condition that you're interested in. And one has to be very careful about defining the population. So often prevalence studies are geographical studies. Often the geographical area is coterminous with the country of the study. But sometimes you have to decide, are you only interested in people who were born in Canada, or are you interested in people who migrated into Canada and brought with them a child with ASD? And the full report goes into those details for you. I've already talked about the age range of the report, and the time range is really data from about 2015 onwards. Because this was a pan-Canadian study, different provinces had data available from different time periods. So if we look at ASD epidemiology in total, I've already mentioned that most of the studies are prevalence studies, and virtually all of the studies are studies of children. There's less than a handful of epidemiological studies counting the numbers of adults with ASD. And one of the reasons that ASD has become more prominent in the public mind is because of the increase in detected rates. So when I was at medical school, I think 5 minutes of one of my pediatric lectures was given over to ASD. And the reason was because the pediatrician giving the lecture said that the rate of autism was about 2 to 4 in 10,000. And if I became a family doctor, which is what my medical school mainly turned out, I would see 1 or 2 patients with autism in my entire working life. Contrast that with the data that William showed yesterday, where you saw this exponential increase in rates. Autism is now a common disorder, and we need to understand what was it that happened that led from 2 or 4 in 10,000 to rates of 1 in 60 odd. And there seem to be 2 things that are particularly important. One is changes in diagnostic criteria, which are inextricably interwoven with clinicians' sensitivity to the disorder. And the other is knowing a little bit about what's happened to the rates of other disorders, because very often autism doesn't exist in a vacuum. People may have other conditions, and therefore sometimes there's an element of chance as to which condition you get diagnosed with first. So William showed yesterday a picture of a painting, actually, of Leo Kanner, who described infantile autism in 1943. And Asperger's account was published the following year, but in German, at the end of the Second World War. So it didn't really receive, in the English-speaking world, the same degree of attention that it would have done if it had been published in English, and perhaps at another time. And in the 50s and 60s, clinicians realized that they were seeing lots of children similar to the children described by Canna, but who didn't quite meet the current criteria for full-blown autism. So these children were given the label atypical autism. Then in the 70s and 80s, clinicians realized that they were seeing large numbers of children who obviously had an autistic-like disorder, but nowhere near the level of severity that Canna had described. And these children were described as having a pervasive developmental disorder, because that was the umbrella term, not otherwise specified. In other words, you fell in the sort of leftover category. And at about that time, because of the work of Lorna Wing and Jutta Frith, Asperger's disorder, as it became known, he called it autistic psychopathy, became incorporated in the diagnostic schema. And then there were a couple of other very neurologically based disorders that were included in the category at the time. And we ended up slowly with this bizarre situation where the majority of children being diagnosed with a pervasive developmental disorder in the 90s and early part of this century got the leftover diagnosis, the PDD-NOS diagnosis. So in a sense, this is not an unusual situation in medicine where you start by being able to identify the most severe form of a condition, and as clinicians get more experience, they get better at identifying milder and milder variants. And so, as I think you will all know, in the DSM-5, we've moved away from this historically based subcategorization of pervasive developmental disorders to saying that they are one of the neurodevelopmental disorders and calling them an autism spectrum disorder. That hasn't made the variation in severity go away. It's simply that it's all been encompassed under one underlying term. So we think that a lot of the increase in the rate of ASD over the last 15 or so years has been to do with this recognition of individuals at the milder end of the spectrum. And additionally, I think the previous presenters were pointing out that 20 years ago, there was a lot of discussion about whether girls and women with ASD were in fact more severely affected than the males. This was an interesting biological topic of conversation, and with the benefit of hindsight, it's very obvious that what had happened was that we were only picking up girls who also had an intellectual disability. Now, I just want to go back to Asperger's syndrome for a moment, because William pointed out that one of his researchers had carried out a literature review of all the epidemiological studies. And in those studies, there are a small number of studies from probably the 90s that focused just on the rate of Asperger's syndrome in the population. And those studies were reporting sex ratios of 1:8 to 1:15. So in a subcategory of people defined as being the most able people with ASD, there appears to have been really gross under-recognition of women. California has had extremely good record keeping for all of these conditions for a number of years. And about 10 to 15 years ago, researchers realized there that as the rate of children identified with ASD was starting to climb dramatically, the rate of children diagnosed with just intellectual disability was going down. So it wasn't just that we were identifying the most able kids that we'd previously missed, it was also that we were getting better at recognizing autistic features in less able individuals. And additionally, the rate of diagnosis of pure language disorders has dropped dramatically over the last 20 years. When I was training, we would play this game when I was presenting to Michael Rutter, who was like the god of autism for many years. We would have a child in front of us and we'd go through this little process of working out, was this due to intellectual disability or a language disorder? That's not a game that's played anymore, because the first question anyone asks when a child presents with a language delay is, do they really have an autism spectrum disorder? So there have been huge shifts in the rates of these different disorders and the way people are educated to detect them, and I think we can anticipate that there's going to be ongoing change. So what we tell you today is not necessarily going to be the truth as such in 10 years' time. Asperger wondered if the condition he described was passed from father to son. So William had this nice quote yesterday from a later bit of writing by him, wondering where were the girls with Asperger's syndrome. So this issue of not picking up girls with, able girls with ASD actually goes back right to the original description of these conditions. And before we get on to the fact report, British Columbia has had a very standardized way of diagnosing ASD since 2007, and the history behind this is relating to the provision of autism funding to families, which required there had to be some standardized mechanism for saying whether someone did or didn't have an autism spectrum disorder. And the system that was set up was that clinicians had to use the gold standard diagnostic instruments, the ADI to take a history of development from parents, and the ADOS, which William showed you some clips from yesterday, which is an interactive assessment with the child or adult. And so there isn't a requirement that individuals meet the sort of cut points on those instruments, because these are essentially research instruments, but there is a requirement that that level of quality of information about an individual has been gathered. So one of the advantages of the BC data is the same type of approach has been used for many years. Karen Bopp, who until recently would send us all of this data, sends these slides out every year, but they're always sent in a format that I can never get it into PowerPoint. But on this occasion, she put it into PowerPoint for us, but it's 2 years out of date. But I remember what the numbers are for this year because she sent them out a few weeks ago. So currently, for children aged between 6 and 18, the rate of ASD in British Columbia is 1 in 51. For children aged, this one is, and this one is now 1 in 58. The numbers, I think, matter less than the slope of the graphs. There's no real sign that this is leveling out yet. And the way to understand this will largely be to do with digging into the fine detail of the level of severity of these individuals and the extent to which they might also have intellectual disability. Because one possible explanation is that the true underlying rate isn't really changing a great deal and that we're just getting better at identifying less severely affected individuals, or it could be that there is also a true increase in the rate of ASD. Now, this is local data, it's always more interesting, but if we had the data for any developed country, it would look the same. The rates are just continuing to go up. But all of this data is on children. The only Canadian data on adults I'm aware of is an informal survey carried out by Kevin Stoddart at the Redpath Centre in Ontario a few years ago, and they sent out questionnaires to adults with ASD, and one of the questionnaires was asking them when they were diagnosed, and half of the respondents were diagnosed after the age of 21. That doesn't mean that's representative of the population at large, because many of the people who were sent questionnaires were probably people who'd been diagnosed by Kevin's system. But it is a useful reminder that the true rate of ASD in the population is not just the rate in children, because so many adults reach adult life without a diagnosis. So the rate in children is, if you like, the minimum rate. Now, the Public Health Agency had really three possible strategies they could have adopted, or three they talk about in the report. One was to take an approach similar to that used by the CDC in the US, and to review individual patient files to check that the person had ASD. A second approach would have been to have sent out surveys to parents of every child in particular areas, asking whether their child had an ASD, had a diagnosis, or had clinical features suggestive of an ASD. And the third approach is to use existing data, what they call administrative data. So that would be health record data, educational record data, social services data on individuals who have a diagnosis known to that agency. There is, of course, an alternative approach, which William mentioned yesterday, called active case finding, where you go out into usually a relatively small population and you knock on doors or put leaflets through people's letterboxes and try to identify everyone with the condition, regardless of whether they have a diagnosis or not. And normally you do this in a tiered way. So you start with a questionnaire, and then if people respond positively to a questionnaire, you usually send them a longer questionnaire, and if they can be bothered to fill it in, you get some other data from other sources, and eventually, if you think the person really might have an ASD, then if you had lots of money, you would bring them in if they were agreeable and do an ADI and an ADOS. That is sort of the gold standard approach, and is, of course, ridiculously expensive to do. It's been done a couple of times for adults, because people have been so Terry Brewer in the UK carried this out for one of the better epidemiological studies of adults. But I think FAC decided that was probably not a good use of taxpayers' money, and decided to go with the administrative data approach. And of course, in different provinces, the data comes from different agencies. But FAC were very keen that they wanted a system that really involved every province and territory in Canada eventually, so that the data could really be viewed as truly Canadian data.